So these are slides from your assessment, and it'll probably be beneficial for you to go back and take a look at it. But we remember with our vestibular system, we have our peripheral system, which is our 3 semicircular canals and the otoliths with the utricle and saccule, and that makes up your peripheral area, and most peripheral problems take place here or on the 8th cranial nerve. The 8th cranial nerve travels to our central processors, to our vestibular nucleus, talks to the vestibular nucleus on the other side, and then information will be sent to the cerebellum and then higher up in regards to the cortex, which is many areas of the cortex, but they have identified the parietal insular vestibular cortex as probably one of the main ones. And then because a lot of this is reflexive, we will have motor outputs. So our vestibular ocular reflex, we will have eye movements in coordination, opposite direction of your head movement. You'll have different reactions traveling down through the vestibular spinal tracts to correct your balance, and your cervical muscles will adapt, as well as there is head motion to right the head. So when we remember with our vestibular nerve that there is a resting rate, and that's critical when we start talking about when there's dysfunction. And so the vestibular nerve at rest will fire about 90 spikes per second, and it will be equal on the left and right side, and because it is equal, the body senses that there is no motion. If you turn in one direction to the side you turn to, you'll have increased firing rate on the side you turn to and decreased on the opposite, and therefore both will send information to the brain, whether it's your left or your right ear. And so the head, well, you can detect motion up to probably 350, 400 degrees per second. But there is a point as you keep increasing speed that it will be detected on the side you turn to, but eventually you'll hit a point where the side that gets inhibited, it will hit a 0 point. And what this means is that as you go at really quick head movements, it's really the ear that you're turning to that will note the changes as compared to the opposite side, because it will eventually hit a point of 0. You remember your brainstem pathways, your vestibular afferent nerve, your cranial nerve 8, traveling to your vestibular nucleus, which is located at the junction between your pons and your medulla. The VOR ocular motor nuclei will be your 3, 4, and 6. Oculomotor 3, trochlear 4, abducent 6. Cerebellar is more our adaptive processor, so it will make adjustments according to error signal coming in. And obviously there's going to be a comparison on both sides of your vestibular nuclei. We'll be talking to each other as well. The VOR pathway is a 3-neuron arc, and this is what produces the eye movements in response to the head movement, and it will be of equal amplitude and speed, but just in the opposite direction. So if your head turns left, your eyes will move right at the same exact speed and at the same amplitude or degrees. The VOR is the only mechanism that can maintain, so when your eyes are equal and opposite, therefore whatever you're looking at stays clear. When you're working at slower head speeds, it's primarily your smooth pursuit system that will allow that clarity in your vision. But as you get up to higher speeds, higher than 60 degrees per second, it'll be primarily your vestibular system. And I believe this is a typo in your other PowerPoint. It says 1, but that is incorrect. If there are deficits in the vestibular system, that's when you get opsalopsia, which is visual blurring as you are in motion. You remember this slide, we don't need to go into detail, but here's out in your periphery, let's say your horizontal canal going to your nuclei. We'll talk to your other nuclei, and then it will give input to, if we're looking for horizontal movement, that will be cranial nerve 6 and cranial nerve 3. That will fire your medial and lateral rectus to turn your eyes one way if your head is moving the other. Now when we talk about the gain of the movement, gain is velocity. So that's the speed at which the head moves, matching the speed as the eye moves. And so if we look at if your head is moving at a certain rate and your eyes will move at exactly the same rate, we put one over the other, and therefore the gain will be of 1. All right. The problem lies in when you have a vestibular deficit and you have the head movement at a certain rate and the eyes actually lag behind. And so therefore you no longer have a gain of 1, and because the eyes are lagging behind, you get this sense of visual blurring. Your vestibular spinal reflex, primarily coming from the otoliths, but also the semicircular canals, and this will be your postural responses, whether reactive, okay, or anticipatory, that will right your body in reaction to different movements of the head or in change in gravity, okay, because remember the vestibular system also plays a role because of the crystals, the weight of the crystals in the otoliths. Changes in gravitation will be reflected in the body. The COR, the cervical ocular reflex, parallels the VOR, and it's thought to contribute more to a slower component eye movement. So remember we talked about vestibular working at those higher rates. Your cervical receptors in your cervical spine, upper cervical spine, will send information also to your vestibular system on where the head is or the head has moved in space. And therefore, sometimes what happens when you have upper cervical injury to those proprioceptives, like in whiplash, or we believe in concussion, or people who have a lot of cervical dysfunction, will often have complaints of dizziness because of that. It is also thought that if the vestibular system is no longer working, with the cervical ocular reflex, the proprioceptors there be able to assist in making corrective eye movements. This is still somewhat controversial, and if the COR does play a role, obviously it's not going to happen at the higher speeds. It would happen at the lower speeds. When we talk about peripheral vestibular disorders, anything between the periphery, the inner ear to the nuclei, the 3 most common disorders that we will see is BPPV, which we will talk about actually in class. Vestibular neuronitis is second, and bilateral peripheral vestibulopathy, when you have involvement in both ears. Both of these, vestibular neuronitis and bilateral peripheral vestibulopathy, are hypofunctioning, either of the one ear or both ears. Some other things that we see, not as common: acoustic neuroma, which we now call vestibular schwannoma, which is a tumor that sits on the 8th cranial nerve. It's benign, it's slow growing. Usually the first signs will be tinnitus or hearing loss, and they will go in often surgically or with gamma knife is often common how they will treat it nowadays, and remove the tumor. Sometimes the tumor will get bigger, grow bigger, and sometimes start putting pressure on 7th cranial nerve. All right. Typically it grows either in the internal auditory canal or also at the closer to the nucleus in the cerebellopontine angle. But once the surgery has occurred, now people present with a vestibular hypofunction, and we would treat it the same way. Meniere's disease is a disorder that involves fluctuation in fluid within the inner ear, and so when fluid is increased, you will get episodes of severe vertigo that will last for hours. There really is no physical therapy treatment for this complaint of vertigo. They usually try to manage it medically, reducing salt in the diet, things of that nature. But if these patients have deficits, either balance or dizziness, in between the episodes of vertigo, then we can treat it in therapy. Superior canal dehiscence is not treated in physical therapy. Again, this is a surgical treatment. We didn't really talk much about it, but what it involves is a thinning of the bone on the superior canal. And so this is very rare, and we do not see this, or we'll treat this in the clinic. That requires surgery. Perilimb fistula also, physical therapy does not treat. This is a rupture in the oval or round window between the middle and the inner ear. There's leakage of the perilimb fistula. Usually this is triggered by some type of trauma, usually, or pressure. Scuba diving is a common cause of this. And again, PT is contraindicated. Usually these people are put on bed rest, sometimes require surgery, but usually when they hyperventilate or sneeze or do something of that nature, they will get vertiginous, and that is typically these two problems. If you suspect them, they should be sent to therapists who specialize in vestibular. So primarily we're going to be talking about treatment of vestibular hypofunction or unilateral vestibular hypofunction, or UVH we'll call it. And this is typically triggered by some type of virus, Epstein-Barr or upper respiratory. And what will happen is there will be destruction of some of the periphery sensory organs, the hair cells, not all of them typically. It can be unilateral or bilateral, as we said. We'll go into that in more detail. It can be partial or it could be complete. All the hair cells can be destroyed. And recovery usually takes 6 to 8 weeks following the beginning of vestibular rehabilitation. A lot of times, though, people will compensate spontaneously for this. They'll have an upper respiratory infection, they'll have severe vertigo and dizziness, they'll start moving, go about their regular life, and the symptoms will totally compensate. People who are poorly compensated, where the symptoms persist, these are the people that we see in rehab. Bilateral vestibular hypofunction, the most common cause is ototoxicity. We talked about this. People who, something toxic destroys the hair cells or damage to the vestibular nerve. Different medications, the gentamicins in large doses or IV will often do it. Different types of chemo can also cause ototoxicity. To a lesser extent, meningitis, Paget's disease, autoimmune dysfunction or disease, and majority is unknown. 50% of bilateral vestibular hypofunction, we don't know why it's caused. All right? These people typically do not have so much dizziness or vertigo. Their complaint is, if the vestibular system is completely off, that they're going to be off balance, their gait will be ataxic, they will have visual blurring, okay, so there's no gaze stabilization, so what they're looking at when they're in motion is moving, and they may have hearing loss if it's occurring on the 8th cranial nerve. If it's in the periphery itself and the receptors, they will not have hearing loss. Now, you can have partial loss of both or complete loss of both. If it's partial, you may have some symptoms of dizziness or vertigo. For instance, if there's an imbalance now and one ear is more involved than the other. So when the imbalance happens, that's when you see the dizziness. But if it was a complete loss, vestibular system completely wiped out on both sides, you're not going to have any dizziness. Recovery kit for this can take up to 2 years, and a lot of times people will have residual deficits. Central vestibular disorders. So this is usually strokes, different types of ischemia or hemorrhage, whether it's in the brainstem or the cerebellar primarily. MS, as we talked about, high incidence of central vestibular problems. Tumors in the central area. Then often a large amount of complaints of people with dizziness is migraine. Migraine is a central problem. It will often sometimes present like BPPV or a unilateral vestibular hypofunction. They can also have vertigo. They can also have imbalance. So this is sometimes deceiving when you're going through your assessment. But history is the biggest key to this. If you hear things like, for women, that it comes and goes during their menstrual cycle, that there's hormonal changes will trigger this. If it's triggered by different patterns of foods that they eat or sleep patterns, things of that nature. If there's a large motion sensitivity component to it, so like riding in the car or movement is problematic. If they talk about phono or photophobia, fluctuating sounds or lights or problems with fluorescent lights triggering their dizziness, okay? And obviously if there's a headache involved. So you can not be involved, but typically they are. So when you get someone who's young, women, primarily in their 20s or their 30s, and they're talking about dizziness. There's no cervical component, there's no positive head thrust, there's no dynamic visual acuity. A lot of times it's often migraine. In this case, we often will refer back to the neurologist or someone who specializes in migraine for medical management. We will often, vestibular rehab is okay if they are also being medically managed, okay? And typically we're working more on exercise, exertion, figuring out their triggers, healthy lifestyle, maybe some vestibular rehab. Concussion or mild TBI, another area that will have a vestibular component. We will often treat this similar to our unilateral vestibular lesions, but we tend to be a little bit more cautious. We, because of the irritability sense, we're careful not to aggravate it. And with concussion, there's different pathways depending on how they present. Concussion people will either present more with vestibular and visual complaints, or more neck pain, headache complaints, or physiologic, meaning that exertion or movement will set off symptoms. So depending on, and a lot of times it's a combination of all, where a lot of our concussion patients, we're doing vestibular rehab while we are treating their neck, and we're doing exertion testing. Wallenberg syndrome, we had talked a little bit about in class the other day. This is an infarct in the lateral medulla. We call this the perfect storm of vestibular problems. This is often can be caused from an infarct in the pica, the posterior inferior cerebellar artery. These patients will present with severe balance problems. They will often have lateral propulsion or the ocular tilt response, in addition to dizziness, double vision. A lot of, think about brainstem signs that they will have in addition, cerebellar signs because of the location for the cerebellar peduncles. Typically with central problems, vertigo is not always the main complaint, more low-level dizziness, okay, for long periods. Obviously recovery can be longer, 6 months, even more so, and it may be incomplete because now you're thinking about, we often rely on the central areas to help us adapt or compensate, and if these areas are involved, therefore we might not have complete resolution of symptoms. Oh, I put a slide on for this. So generalized dizziness for TBI and concussion provoked by head movement does respond to vestibular rehab, as we said, will take longer compared to peripheral. And then we talk about the different treatment pathways depending on the symptoms. And you might see balance deficits that you will treat as well. So one of, as we remember for our assessment, deciding, because sometimes it's not as obvious. I mean, if they're MS or stroke, it's an obvious, but sometimes people just come in reporting of dizziness, so you're not sure, is it central or peripheral? We remember that when we look at the nystagmus that's present in daylight and doesn't suppress when you visually fixate is often central. If the nystagmus changes direction, okay, so it beats left when you look left and beats right when you look right, or it's a pendulum, it might just change spontaneously, okay, or if we see other neurologic symptoms, okay, that are indicative of central. Peripheral, the nystagmus will often suppress with fixation. The direction of the nystagmus will always be unilateral. So if you have a left ear problem, the nystagmus, remember, the fast phase will be in the opposite direction, regardless of the position of the eyes or the head. You might have symptoms that are dependent upon position, like BPPV. Your nystagmus, you might see some torsional BPP as well. Torsional nystagmus with BPPV. Okay, so this is what we've been waiting for, the interventions. So, acutely, let's talk about somebody who has an upper respiratory infection. Some of you might even be able to recall back that this has happened to you. They typically wake up and they are spinning. They cannot walk. They are off balance. All they really want to do is close their eyes. Okay, so this is an acute vestibular attack. People, if they're older, often think they're having a stroke, so they go to the emergency room. And they obviously will do CAT scans, rule out any type of infarct or any other major central problem. And they will put them on meclizine, which is another word for antivert. This is a suppressant. It will quiet down the vestibular system, okay? Long-term use of this will limit recovery, okay, of balance and the visual gaze stabilization. So the meclizine should just be used initially. One of the problems with meclizine is that it slows down your mental processing, your reaction times, it makes you sleepy, and we know that we need to drive the system for adaptation, so we need to experience the dizziness, okay? Initially what will happen is that you will have a static component or a tonic component, meaning that you will have nystagmus at rest. You don't need to have them look left and right. It will be often present in daylight, so people cannot stop it, the nystagmus. And this will usually last anywhere from 2 to 3 days. And typically we don't see these patients, right? Because the static component will correct itself. The vestibular nuclei will correct for your initial acute problem. What will happen then for those people who don't compensate or poorly compensate and continue to have now dizziness or imbalance in the dynamic component, meaning when they're in motion, okay? Those are the people that we see in a vestibular rehab program. And our goals for these people is to reduce their subjective symptoms of dizziness, which we usually pick up on the DHI questionnaire, improve their gaze stabilization, meaning that things will not be blurry when they're in motion. We test this with the dynamic visual acuity and how many line difference, improve their postural stability in different sensory environments, closing eyes, on unlevel surfaces with movement of the head. So that would be static. Dynamic would be now more with moving the head, moving the body, walking, okay? A lot of these people will have limited cervical range of motion, and it's not because of a cervical injury, unless of course it's concussion, but it's typical because they know that if they move their head, they're dizzy. So they stop moving their head, and so they wind up getting stiffness. So sometimes we need to increase range of motion. We put them on a walking program or increasing their physical activity levels, okay, so they can tolerate that and improve their fitness. Obviously, if they're older and they have other comorbidities, they might be at full risk, so that is a goal. And a big component is these people are usually anxious, they're stressed. So making sure that they realize this will go away, they will return to their pre-morbid situations and return to their lifestyle. So vestibular rehabilitation is interventions that will eliminate or decrease the symptoms, okay, that are associated with peripheral vestibular pathology. There are 4 components of this. One is gaze stabilization. So this is all with the ability to stabilize your eyes when you're in motion. That will occur both through adaptation and or substitution, depending on the type of situation or problem. We're going to get more into explaining this. We might do habituation exercises that we provide a noxious or provoking stimuli in repetition again and again, where the body no longer is aggravated by this. All right. This includes optokinetic stimulation that we will talk about. We will do balance and gait exercises as appropriate, and the aerobic component that I talked about, typically a walking program. Recently, in the Journal of Neurologic Physical Therapy in the April 2016, they came up with the vestibular group, and the neurology section came up with a clinical practice guideline for peripheral hypofunction. It is a very long document because it goes through all the research, all right? But to summarize for you, which I have done, is that there shows that there is strong evidence for the effectiveness of vestibular rehab in persons with either acute, subacute, or chronic unilateral vestibular hypofunction or bilateral vestibular hypofunction. So that just states that the evidence proves that what we are doing is effective. Okay. There's also strong evidence that doing just saccades and smooth pursuit eye exercises are not effective in isolation. meaning that you can't just work on moving your eyes. Head movement has to be involved as well. They came up with some optimal exercise doses, that it is key that patients, when they are in rehab and given their exercises, that they do the gait stabilization exercises daily, at least a minimum of 3 times a day, up to 5 times a day. In acute cases, we're doing it for a total of about 12 minutes, and for chronic, we are increasing it closer to about 20 minutes. So now when we talk about treatment, there's 3 different types of interventions that we will, and there's often overlap in all of these. But one thing is that we're looking for adaptation, that these are long-term changes in neuronal responses to head movement. This goes back to your firing rate, or your ability to match your eye velocity to your head velocity. Okay? Your static improvement that happens initially in the first few days is that adaptation happens at the vestibular nucleus level. When we now look at the dynamic changes, okay, with motion, it is believed that a lot of that adaptation happens more at the cerebellar level. There's also habituation that we talked about. So that's a decrease in behavioral response to repeated exposure to provocative stimulation with the goal of reducing symptoms. We will often give habituation in positional exercises or in situations where full adaptation doesn't occur and people continue to have chronic dizziness. And then we have substitution. Okay, so substitution, as you know, promotes an alternate strategy to substitute for missing vestibular function. It is believed, in addition, that even if there is not complete loss of vestibular function, that some amount of substitution will occur along with adaptation. But we definitely know for people who have bilateral vestibular loss completely, we now have to substitute with other compensatory saccadic eye movements for gaze stabilization, and obviously using proprioception and visual system to help manage balance and ambulatory problems. So for the adaptation approach, this is appropriate for patients with reduced vestibular function. What we ask is that patients work through their symptoms. So a lot of times patients come in and you're going to be asking them to do eye exercises with head movement that make them dizzy, and they do not like you. You will experience this in lab. Typically, though, we tell them, if we're using a visual analog scale from a 0 to 10, and we're looking at, well, how stimulating is this? We don't want to be working up in the 7 or 8 levels. We want to keep it down below 5. So somewhat stimulating that they can tolerate, no longer when they're done with their exercises, that symptoms do not last longer than 20 minutes when they have completed. Okay. The key thing to the adaptation is that one needs a retinal slip. So retinal slip means that the image of the object that you were looking at moves off of your fovea. Remember, that's at your back of your retina where your central vision is most accurate. All right. And as the retinal slip occurs, you're going to have blurring. This is absolutely necessary to drive vestibular adaptation. All right. So in order to get retinal slip, there has to be movement of the head. And that's why saccades and smooth pursuit alone is not beneficial. All right. And therefore, this retinal slip is the signal to the brain, to the cerebellum, that says, hello, something is wrong here. We need to correct this. So this, I'm not very good at graphs, but if we look at on our y-axis being the speed in degrees per second, and ignore these numbers, I couldn't change these, but we know that we're working at degrees for vestibular higher than 60 degrees per second, and we can be going up to rates of 400. And if this in time in milliseconds, what I wanted to demonstrate was with someone with your eye, without a vestibular problem, that if the orange was your head velocity, that your eye velocity should match it, okay? Would be equal and opposite, all right? So the same amount, if you're moving at 100 degrees per second of your head, your eyes are also moving at 100 degrees per second. But this is what happens with our vestibular hypofunction people, okay? That now our gain or of our eye velocity, if we put it in a formula, over head velocity would no longer equal 1. Okay, so if head velocity was 100 degrees per second, and eye velocity would be 100 degrees per second. 100 over 100 equals 1. All right. And there's equipment now that they can put goggles that will measure your head speed, and there is like a VNG can pick up movement of the eyes, will pick up eye speed, and we can give you a formula of what the gain is and in what direction, because it will always be worse in the direction that you are turning toward. So what types of exercises do we do for adaptation? Well, you will hear about times 1 or times 2, and it's actually VOR times 1 or times 2. And so you are having visual fixation first for VOR 1 on a target that is not moving, and we're going to ask you to move. Usually we start in the horizontal direction, okay, and then we will move to the vertical direction. We will usually start people doing this for 1 minute, all right, 3 to 5 times a day, for if it's chronic, to the 20 minutes per day, okay? And their whole goal is that they move at a speed at which the target stays clear, okay? And then you attempt to go faster. But if there's too much visual blurring, meaning too much retinal slip, you need to slow down, okay? We usually will start with a large target, okay, something that people can look at, and move to smaller and smaller targets like a business card, all right? People wear glasses. They should wear glasses because we want corrected vision. We usually start at arm's length distance from the target, so we tape it on the wall, and then we have them move back. And we're constantly progressing this and making it harder, either longer time, more repetitions, smaller targets, larger distance from the target, using a full field visual stimulus background, like putting the letter or the business card on a checkerboard, or making them stand in front of Venetian blinds, okay? Or you progress to walking or dual tasking. The list is endless, okay? When another progression of that is now moving VOR 2, or paradigm times 2, is that you're looking at a moving target, okay? So now you're holding the target, and the target is moving one way, and your head movement is moving the other way, okay? The other thing to keep in mind, patients will notoriously move their head in too large of a plane. So they're moving into like 70 degrees of horizontal movement. It should be closer to like 20 degrees either direction. It's small amplitude. We're working more on speed. Different now than our Parkinson's, right? With Parkinson's, we're looking at big, large amplitude. With our VOR, we don't need that because oftentimes they will aggravate the neck. I put the B here because I will explain the B when we get into clinic. Remind me to tell you the story of the B. Okay. Now, with substitution, so for people who have incomplete or complete loss of bilateral, and we will find that as we'll always start with VOR, okay, because we don't know exactly how much vestibular loss is present. So there might be the ability to have some adaptation, okay? But if you have people who have dynamic visual acuity of like 2200 visual acuity dynamic versus their 20/20 over static, and you're doing regular VOR and you're not making changes in this, this is when we say we start moving into different types of substitution eye exercises. So now we're relying on visual, okay, like saccadic compensatory movements, or relying on somatosensory information, not only from their lower extremities for their balance, but also from their cervical proprioceptors for gaze stabilization as well as alignment issues. Oh, that's what I say right here, cervical spine proprioceptors. Okay, and in lab we will be going over some of these. We are also hoping that by targeting the cervical ocular reflex, we are bringing in input. This will be obviously at slower speeds. It's done the same way as VOR, where you visually fixate and you just move at a slower direction, okay, a slower speed. So Herdman states that the identification of the COR as a means of gaze stabilization is controversial. But I've seen some improvements with it, and you're going to start with VOR at slower speeds anyway, and we'll teach you in lab how to calculate when you start getting to higher speeds when the vestibular system is taking over, okay? Here's some example things that you're going to teach patients is to fixate on something stationary. So dancers, ice skaters already know how to do this, right? So it's like targeting. When you come out of a spin, you find something that's not moving. So our patients with severe vestibular problems, bilateral, will often teach them to visually focus on something stable before they go to do a turn, or if they're moving, okay, to help with their balance. The other thing that we're going to do in lab is active eye movements between two targets. So if we look here, we turn the head and the eyes to target 1, and then we just move the eyes to target 2, and then the head. So pretty much what we're teaching is a saccadic eye movement, so the eyes move first, and then the head. And can the eyes stay fixated on this target when the head moves? The other thing that we do a lot of is imaginary targets. So you look at the target, you close your eyes, and you try to visually imagine that you're looking at this target. You move your head, and either you open it when your head is turned, or you come back to with your head righting toward it, and are you still on the target? And we'll show you different ways to work with that in lab. Habituation we use for people with patients with continued complaints of dizziness, and again we repeatedly expose them to movements or position that provoke the symptoms. We will often use the motion sensitivity quotient or test. That was those 16 different positions, and patients rate them, the amount of subjective dizziness on a 0 to 5 scale. And so we look at, well, what's most provoking? What position bothers them the most? Bending over, moving their head, lying down. And we ask patients to practice this so that they, usually we will do this for about 2 weeks, and we should start seeing some reduction in symptoms. And these were the first vestibular exercises that ever came about. When you hear people talk about Cawthorn or cookie exercises, those guys, that's when they were doing more position and saccades and smooth pursuit. So we've advanced from that. Brant-Darrif, you will see when you read in your textbook that they often use this for BPPV treatment. That is not correct anymore. We don't use it for BPPV, but we will use it now for people who have positional dizziness that is not vertiginous, causing vertigo, but just dizzying. So we use it for habituation. We use it for cupulolisthesis, though, or when repositioning maneuvers for BPPV are unsuccessful. We usually find 2 positions that are problematic. We'll ask patients, we usually start 3 to 5 repetitions and work up to 5 to 10 repetitions of that noxious position, and they do that 3 times a day. And we usually will continue until patients are symptom-free for 2 days, and then we will retest and make sure that those positions are no longer a problem, and now we'll move to another position. You don't want to give them, as I said, more than 2 exercises. That would be too irritative. And if it's bringing on levels of 7 or 8 levels of dizziness, that's too much, and you need to back off of that. Okay, here's just an example of the Brant-Darrif. You turn your head one way, like you turn your head to the left. You lie down on the right. You wait and see if you're dizzy. You wait a maximum of 30 seconds, see if the dizziness disappears, and then you come back up. And then you do it again to the other side, and you come back up. And that would be 1 repetition. So maybe you would start doing that 3 times, work up to 5, and up to greater amounts. Also for habituation, we'll use optokinetic stimulation, and I'll show you this in lab. But this is people who have visual vertigo, meaning that they get dizzy when there's things that move in their environment, not when they're moving. And so we can pull these up on YouTube, but this will move like an optokinetic drum, whether it's vertical or horizontal, and we'll have patients actually watch them. We have a whole list of obnoxious videos, kind of like you go to IMAX, the 360 surround visual stimulation, like when you go to Disney. This is what these people hate, and so we try to have them watch these on large screen TVs while they're doing different balancing exercises. Obviously, we're going to do balance and ambulation retraining. You already know how to do that, so we're not even going to bother with this in lab, but we're changing the sensory stimulation. That is key, okay? We will change the visual input. We will change the somatosensory input. So uneven surfaces, occluding vision, so eyes closed, or blurring it with like Vaseline on goggles. We can alter the visual input, and obviously we want to stimulate the vestibular system. So anything with head movements, body movement is key. And lastly, we want to do ambulation retraining. So we're going to be looking at walking with head turns, both horizontal and vertical. Diagonal head turns we will progress to. Walking, doing a 180-degree turn, or then a 360-degree turn. Walking in circles, gradually making the circumference smaller. Walking with eyes closed. Doing the VOR while you're walking. Doing the singleton, like the quick walks and the 360 degrees, or it's 180 degrees, feet together, eyes closed, hold that Romberg position. And so, depending on what you find in your assessment, is where you are going to be focusing on. Okay, so I'm going to end there because BPPV I'm going to do within, I'll do this lecture, this part of it in class. This one's better live. And then we're going to practice all these things. Okay, so I'm signing off and stopping recording.